So the topic is European Society of Cardiology Heart Failure Guidelines Update. And I love these topics, because you don't know the meaning. It means that I should present the guidelines of the European Society of Cardiology that were published just 1 year ago, or should I update the guidelines in what has been happening in the last year? So let me start with the algorithm of the European Society of Cardiology guidelines for the treatment of heart failure. And the starting point is the diagnosis, There is a number of patients that in whom a diagnosis is misleading because heart failure is not properly diagnosed, or so we are missing patients, or we are labeling patients with heart failure when they have not heart failure. So it is very important to follow this algorithm. So when you suspect heart failure because of symptoms or signs, let's say dyspnea or edema, leg edema or whatever, you have to confirm heart failure, and that is very important. And then you have to start the treatment. And one of the things that the last European Society of Cardiology guidelines is focusing and making an important stress on the importance of this is the biomarkers used in the diagnosis of heart failure. And in fact, they recommend the use of BNP if possible, because it is not so cheap. It is something like 15 euros or something like that, from 15 to 50 euros. And that is nothing in compared with the cost of heart failure and the hospitalizations and so on. But it is not really available in all the hospitals. So the starting point is when you suspect heart failure, you obtain a blood sample to measure natriuretic peptides, and the levels for suspecting heart failure and continue the algorithm are really very low. NT-proBNP is above 125, and that is the real low limit for suspecting heart failure. But even in the presence of symptoms, if BNP is normal, you have to think about something else, The dyspnea or the edema is not secondary to heart failure. And if it is elevated, you have to continue with the algorithm. Or if you don't have the BNP levels, you can go straight with an imaging technique to evaluate the left ventricular function. And echocardiography is the imaging technique that is available in virtually everywhere in all the hospitals. So if there is, especially if there is a positive BNP, BNP is elevated and echocardiography is abnormal, with left ventricular function abnormalities, heart failure is confirmed, you have to determine the etiology, try to identify factors that can be corrected, but the diagnosis is properly done. And another thing that is, the second thing that is stressed in the, or highlighted in the guidelines of the European Society of Cardiology is a level of left ventricular ejection fraction that is between the so-called heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. This includes a myriad of patients, a high number of patients that are now a group labeled as mid-range ejection fraction heart failure. So it is symptoms with heart failure with a left ventricular ejection fraction between 40 and 49. And we don't have much information about what to do with these patients. Usually we treat these patients as if there were patients with a reduced left ventricular ejection fraction, but the recommendation of the guidelines is to explore and investigate or do research in this group of patients to see what is the prognosis, what is the treatment that is having an impact on the outcomes of the patients. So let me move to what should be the core of the presentation in a pharmacology or clinical pharmacology meeting. That is the medical algorithm for the medical treatment algorithm. And the starting point is this slide that highlights the groups of drugs, or the drugs that have been clearly related with an improvement in prognosis, an improvement in outcomes of the patients with heart failure and left ventricular reduced left ventricular ejection fraction. And these include beta blockers, ACE inhibitors or ARBs, and ALDO inhibitors. That is clearly demonstrated in different trials, so that is a clear indication, class 1 with a level of evidence A, so several trials, direct trial, multi-center trials. Then we have hydralazine and isosorbate dinitrate with a single trial demonstrated an improvement in outcomes. And the latest thing we have is the sacubitril valsartan study demonstrating an improvement in prognosis in patients with heart failure as compared with ARBs. So this is the core of the many things we are using for heart failure for many times, including diuretics, digitalics, nitrates, and so many other things. But this should be the core for the treatment of heart failure. And this is the latest information we have to include in the guidelines. It comes from the paradigm. You see that sacubitril valsartan is having some impact in prognosis as compared with enalapril, which opens a tremendous opportunity for investigation, for research. And maybe this new drug should replace enalapril, but with a single trial, the role of this compound is somehow limited. So this is the algorithm of the European Society of Cardiology. It may look like a complicated algorithm, nothing to do with the impressionist algorithm that Dr. Garcia Moll has presented a few minutes ago with an impressionist description of what you should use in diabetic patients, but it is not so clear. So let me focus in parts of the algorithm. So if you made a diagnosis of heart failure with reduced left ventricular ejection fraction, the recommendation of the guidelines is to use ACE inhibitors and beta blockers. That is the first line treatment. And the surprise here is that ALDO blockers are in the second line treatment for patients with left ventricular ejection fraction below 35% and still symptomatic. And I think I disagree with that, and probably some other members of the panel will also disagree, because there is a fantastic information about the benefit, the clinical benefit of using ALDO blockers in patients with heart failure and left ventricular ejection fraction reduction. There are at least 3 trials, the RALS, the EMPhASIS, and the EPHESUS, that demonstrated an improvement in outcomes, an improvement in mortality and hospitalization. And even in patients with preserved left ventricular ejection fraction, there is a hint that the use of spironolactone or ALDO blockers may be of some benefit if you select the appropriate groups. So I think that is something to discuss or to argue in favor or against the recommendations, the guidelines, the use of ALDO blockers in patients with heart failure. If we move further down, another surprise may be that this new compound, sacubitril valsartan, is a really third line in the treatment of heart failure. And it is only because, not because of the results of the trial, but because of the, there is only one trial. So we need more information, and the prospects or the future of these new therapeutics probably is the target should be to replace the ACE inhibitors in the treatment of heart failure, but really to replace something that has been there for so many years with so many trials demonstrating benefit. A single trial is not enough. So it's a second line when the patient is still symptomatic and is able to tolerate ACE inhibitors or ARBs, then you have to think in that. And it is not a surprise that hydralazine is a fourth line, so to speak, treatment for patients that still remain symptomatic in despite of all the therapies. So this indication illustrates the difficulties to demonstrate something that is really useful for a significant number of patients. We have a trial with a reduction in mortality, and it is just in the fourth line of treatment. So imagine what we can do with digoxin or diuretics or things like that, if you think not in reducing symptoms or improving or controlling symptoms, but improving outcomes. Another thing that has been somehow neglected for many years is the drugs that should be avoided in patients with heart failure. And I'm afraid that the list of drugs that may impair left ventricular function and may increase symptoms in patients with heart failure is increasing all the time. We have non-steroid anti-inflammatory agents, we have metformin, some anti-diabetic agents. We have the classical verapamil and diltiazem, doxycycline, anti-Parkinson drugs, anti-cancer drugs. That is growing evidence that there is a topic that should be discussed in detail and defined with information that we don't really have right now. And so that is a topic or a point of discussion that is growing in interest and evidence. And so this is the guidelines, recommendations for patients, for the treatment, medical treatment of patients with heart failure. But to update the guidelines, you should point out some failures and promises since last year publication of the guidelines. And one of the failures is this disappointing news that seralazine fails to meet the primary endpoint in the phase 3 RELAX acute heart failure 2 trial. It was presented, the results were presented during the Heart Failure Congress just a few months ago, the European Heart Failure Congress, and the trial was negative. There was an improvement in symptoms, but it didn't improve the outcomes. So the program with seralazine was discontinued. Even the other trials that were going on were stopped. And it will be a matter of discussion, because I think that when a drug is showing some benefit to improve clinical symptoms, there is a place for this drug to be used in heart failure. We have so many things that we are using in heart failure without the demonstration of an improving in outcomes. That we should not neglect anything that is producing some kind of benefit. But anyway, I think that the cost-effectiveness balance is playing a role here, and that is out of the way. The same is true for the true acute heart failure trial, that was also somehow presented in the last meeting of the Heart Failure Association in European Heart Failure Association. That was a negative trial. There was a morbid mortality trial. It improved the symptoms in patients with acute heart failure, but it didn't improve the outcomes. And it is incredible how many trials we have ongoing trying to demonstrate an improving in the outcomes in patients with heart failure, with reduced ejection fraction, or even in patients with preserved ejection fraction that are ongoing. We have one trial with several trials with sacubitril/valsartan, but especially one that is focusing on the outcomes in patients with preserved left ventricular ejection fraction. We have another promise, that is the use of dapagliflozin in patients with left ventricular ejection fraction reduction and heart failure. There is the vericiguat, some inotropics. There are not one but 3 or 4 trials with iron, focusing on anemia in patients with heart failure after the failure of the RED trial using erythropoietin to control anemia in these patients. So let's see what happened. And then we have a trial with anticoagulation to improve outcomes, in fact, with rivaroxaban. And then we have some others. So it is incredible how many trials we have right now ongoing, trying to improve the prognosis and the outcomes of patients with heart failure nowadays. And so I think that is all. We may have some time for discussion, but my conclusion couldn't be other that the best thing to do right now is not to question the guidelines, but to follow the guidelines. And if you have any doubt, just look at the marketing of the European Society of Cardiology, and I will follow these guidelines to the end of the world. Thank you.